In the Birmingham metro area. Birmingham's mayor and police chief were joined by the county sheriff, district attorney, and U.S. attorney of the Northern District of Alabama.
Hey guys, we will get started in just a couple of minutes. Give folks a couple more minutes to show up. All right, we will start at 12:05. So appreciate you guys showing up on time. We'll wait one more minute and then we will go ahead and get started. Okay, let's get started. Everybody can see me okay, hear me okay, see my slides. If there's any issues, y'all speak up or throw it in the chat or something. All right, so today, kind of want to talk about several different things, all related to pain and opiates and pain management. Bit of a hodgepodge of stuff, but I think we occasionally do a poor job of managing our patient's pain, and at the same time, I think we occasionally do a poor job with opioid stewardship. So I think this is a worthy topic to spend some time on, and I think it can make a difference in your clinical practice. Okay, I've got no financial disclosures. Like I said, today's a bit of a hodgepodge, so we have a lot of objectives, but we're going to go over how to define pain and how it's both a physiological and an emotional phenomenon. We'll talk about the different categories of pain. We'll briefly talk about how to assess pain. We'll go over the goals of inpatient management, and most importantly here, what I want y'all to take away from this is to be able to develop a multimodal approach to managing acute inpatient pain. We'll cover the risks and benefits and indications of the different drug classes, and lastly go over a few resources that are available at UAB to help with pain management. Okay, so let's frame this subject a little bit. This is a question that I often ask my students and my residents, and it's obviously subjective and just my personal philosophy, but as providers, what do you guys think is our greatest responsibility and single most important obligation that we must fulfill for our patients? If you guys have any thoughts, you speak up or throw it in the chat, or we can just be quiet for 15 seconds and then I'll proceed. I like that, Beverly. Do no harm. Yeah. Don't know if I could have said it better. Yeah, I think that's a great starting point and related to this. But the way that I look at it is, I think my greatest responsibility as a doctor and my most important obligation is to ease suffering. And I think that truly encompasses every patient I encounter, whether it's a social admit or somebody dying from cancer or whatever the case may be. Our job as providers is to ease our patients' suffering. And it's not to make a super rare diagnosis or to come up with and implement a perfect treatment plan for heart failure or perform that cholecystectomy. All those things can ease suffering, but I think this is our primary role. Sometimes it's doing things like I mentioned. Other times it's just sitting on the foot of the bed and listening to the fears of an anxious patient. So we can't eliminate it, but I think our goal for every patient is to try to ease their suffering. Okay, so start with a basic kind of biological definition. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Okay, but we all know that pain is not so straightforward, and we know that the perception of pain is really complex and multidimensional. A few points here that I want to cover. Now, I think we all know these. These are obvious once you read them, but I just want to kind of read these to you, and I loathe reading slides to people, but I think these are important points. So just want to cover it. So, we know that the quality, the strength, duration, location, and the degree of unpleasantness is highly individual and is not directly related to the nature and extent of the actual tissue damage. My kids, for example, they could be run over by a bus and they would get up and shake it off. But if they brush their knee against a cushion and get one speck of blood on their skin, it's game over and we've got 20 minutes of crying. And so there's more to pain than just tissue damage. The other thing is perception and reaction to pain are influenced by many, many factors. It's not just tissue damage. So genetics play a role, development plays a role, there's psychological, social, and cultural variables as well. And then situational and emotional factors that exist when we experience the pain can profoundly alter how we perceive that pain. So, for example, if you've got a patient who suffers from depression that breaks their arm, they're probably going to experience a lot more pain than the patient who doesn't have depression and breaks their arm in the exact same way. So there's more to it than just pain. So all that kind of summarizes into saying that understanding and treating pain is more than just knowing this diagram or understanding what's going on neurologically behind the scenes. It really only makes up a small percentage of pain perception in patients. So there are different ways to think about pain, and I generally like to put them into these three different buckets. Now, these are not mutually exclusive descriptions. In fact, pain often coexists in many of these buckets, sometimes all three. But I think it's important to try to develop a framework as to how you think about pain, because it may affect the different treatment methods that you consider for patients who are suffering from this pain. So nociceptive pain is what we classically think about when we think about pain. It's pain due to tissue injury or a harmful stimulus that's been detected by pain receptors within the nervous system. Okay. And then we have neuropathic pain, which is pain due to actual injury to the nervous system itself. Neuropathic pain can lead to allodynia or allodynia, which is pain from sensory stimuli that is not normally painful. So you can think about your diabetic neuropathy patient who just wearing a pair of socks may be painful to them, but that's not normally a painful stimulus. And then lastly, we have central sensitization pain, which we've all taken care of patients with this type of pain, which is pain that occurs in the absence of tissue injury, and it's caused by overactivation of the nervous system. And that can lead to hyperalgesia, which is pain out of proportion to the stimulus causing it. So these buckets and these terms are important when it comes to categorizing pain. All right, so how do we assess pain? It seems like a pretty straightforward question, and generally it is. Most commonly, there's two different ways that we do this. We have the numerical rating scale that we ask all our patients. Virtually every time a nurse sees them, they're asking the patient, "What's your pain score? What's your pain score?" There's also this classic Wong-Baker FACES pain rating scale, which we don't really use in the adult world, but it's commonly used in pediatrics and very helpful if there's a language barrier between the provider and the patient. But there's more of assessing pain than just asking what their pain score is or asking what smiley faced best fits with their level of pain. You really need to understand the degree of functional impact that pain has on a patient. That's really critical. And so as providers, when we're asking about pain, don't just ask about the pain score. You want to know how is the pain affecting your mobility or activity level? How is it affecting your sleep? How is it affecting your personal relationships with other people? These things are really important. We'll kind of come back to how we can maybe address those, but you can't truly get a sense of pain, the degree that pain is bothering a patient just with the pain score or just with picking out a frowny face. So we also need to remember, like I alluded to earlier, pain is highly subjective and personal. So a score of 3 for one patient may be tremendous and may greatly affect their quality of life, whereas a score of 8 may be completely tolerable for another patient. And we have to remember that patients have biases when it comes to pain perception. So certain patients may view pain as a weakness, and those patients are more likely to suffer and more likely to present with other somatic complaints. And so pain may be the greatest thing that's bothering them, but that may not be the symptom that they share with you. At the same time, we providers have significant biases. If we view pain as a weakness, we may not truly experience or truly appreciate the extent that the patient is suffering. And let's not forget that providers frequently under-recognize and under-treat pain in women, pain in the elderly, pain in minorities. Okay, so all these things heavily influence how we assess pain. Okay, so before we go on to different types of treatment approaches, let's kind of talk about the goals of pain management. So, of course, the obvious one is symptom reduction, and there we're talking about getting their pain better, so getting that score lower. But we also need to work toward minimize suffering. And so suffering takes into account the emotional component of pain. And so there are plenty of situations where we may be able to lower that pain score, but their suffering is not necessarily diminished. So that in and of itself needs to be an additional goal of pain management. And then of course, we really want to try to minimize the degree of functional impairment, okay? So in the late 80s, early 90s, the WHO came out with this pain treatment algorithm that I think was initially designed for cancer patients, but since it's been expanded to all patients with pain. I'm not a huge fan of the WHO ladder, mainly because it makes a distinction between weak and strong opioids. And in due time, we've realized that designation is kind of pharmacologically inappropriate, and that these weak opioids have just as much of a potential for harm as our more strong opioids. So I think this is a good start, but I'm not a fan of this. I prefer a stepwise approach that looks like this. Okay, so at the beginning here on the left, all patients in pain, we need to be implementing non-pharmacological approaches, and we'll talk about all of these. If pain isn't controlled through those approaches, we escalate to adding non-opioid pharmacotherapy. And if that's not getting us where we need to go, that's when we add in our short-term use of short-acting opioids. Now, pay special focus to the fact that we're not saying, okay, these non-pharm approaches didn't work, now let's just do non-opioid pharmacotherapy, or those first two things didn't work, let's stop those and do opiates. It builds. So each level builds on the prior step before. A patient should not be on opioids unless they're also on several non-opioid meds, and unless they have non-pharmacological approaches. So that doesn't mean if a patient comes in with a broken femur, you have to say, well, we got to try Tylenol first. The point being is that, yes, you can start opioids at the beginning, but we need to be implementing all of these other therapies at the same time. Okay, well, we're going to go through this in more detail, and then this arrow down here at the bottom is critically important. We have to make an effort to address any coexisting psychiatric condition or any coexisting social issue. These are often very challenging and not things that we can fix easy, but if we're not addressing those, we're not going to get to that point where we can minimize suffering. Okay. So let's break these down just a little bit and look at some non-pharmacological approaches. Now, all of these things are available at UAB. So first up is just self-care. This is kind of like Health Class 101, that old RICE acronym. We forget how effective ice and heat and elevation can be. There's certain medical conditions where you may not want to implement some of these, but don't forget about them. Okay. And then we have these complementary therapies. I really like these. These are heavily underutilized at UAB. We need to be considering these on every single patient that we have that's in pain. They are readily available, they're inexpensive, and they essentially come with no risk. So that includes things like music therapy, pet therapy, pastoral services, arts and medicine. We'll talk a bit more about these, but we can't forget about these. Of course, rehab is really important. PT, OT. If a patient's in pain and these services haven't signed off yet, or there's not a medical reason for them not to be ordered, virtually every patient in pain needs to have these services ordered. Okay. And then lastly, exercise and mobilization is critically important, or even things as simple as stretching in the bed. All of these have a great impact on pain. And in fact, there's evidence that shows that many of these interventions are actually more effective than opiates. Okay, so let's move on to non-opioid pharmacotherapy options. So this list is obviously not all inclusive. I'm just providing some examples. So of course we've got Tylenol, which is kind of in its own bucket. We have NSAIDs, there's a dozen of them, but these are kind of the three that I use frequently. We have different topical agents, muscle relaxers, and our Gabapentinoids. So these are kind of our main classes of non-opioid pharmacotherapies that we use. So let's go into each of these in a little bit more detail. So Tylenol or acetaminophen. Here I say the mechanism of action is not well understood, and it's not because scientists don't understand it, it's because I don't understand it. I read about this for a while, and I checked many different sources, and frankly, I never could quite grasp exactly how acetaminophen worked. But bottom line is, it worked. So, up until a couple of years ago, most patients, it was okay to dose up to 4 grams a day. In the last few years, with increasing cases of hepatotoxicity, we've backed down on that a little bit, and the conservative dosing is 3 grams, though frankly, most patients can handle 4 grams just fine, especially if you're in the hospital and able to monitor them. Obviously, if a patient has a history of heavy alcohol use or chronic liver disease, we set our limit at about 2 grams. So there's really only one contraindication for Tylenol that I could think of, and that's acute liver disease. Again, that doesn't apply to chronic liver disease, where it can frequently be used safely, but acute liver disease, can't use it. And obviously hepatotoxicity is the thing that we worry about. So kind of the take home points here. Basically, if your patient's in pain and there's no contraindication, every single one of them should be on Tylenol, period. We really got to do a lot of education with Tylenol. A lot of patients are hesitant to take it, or they frequently say, oh, Tylenol does nothing for me. Those patients we need to spend a little bit more time with, going over the efficacy of Tylenol, not only as a primary agent, but its synergistic effects as well. So when we add it to other drugs, it's not just truly an additive, it can act synergistically and help more than individual agents on their own. And of course, we got to be really mindful to educate patients about taking over-the-counter drugs that frequently have Tylenol in it. So basically, get your patients on Tylenol if they have pain and there's no reason you can't, and make sure you spend some time educating them. Okay, so NSAIDs. NSAIDs block COX, or cyclooxygenase. That enzyme is responsible for the formation of prostaglandins and thromboxane. So what do those two things do? So prostaglandins do a lot of stuff. They mediate inflammation, they're vasodilators, they affect gastric mucus and gastric acid secretion, they affect platelets as well. And then thromboxane has platelet effects and is a vasoconstrictor. So when we give NSAIDs, it's this green term here that is the benefit. All these other things really can lead to negative side effects, but they're great at mediating inflammations. That's why we use them. But we need to be mindful of all these other potential downstream effects because we're blocking prostaglandin synthesis and thromboxane. So looking at all those things in red, you can understand how NSAIDs reduce renal blood flow, which increase your risk of acute kidney injury or worsening chronic kidney injury. They can promote peptic ulcer formation through decreasing gastric mucus secretion and increasing gastric acid secretion. They affect platelets, which can cause GI bleeding. They put you at much higher risk for cardiovascular events. So with the type of patients that we care for, you can see how virtually all of them have some contraindication. My guess is maybe 15% of my patients can actually take NSAIDs safely. So we're limited, but they work very well if your patients can be on them. So in general, you probably need to avoid them in renal disease, liver disease, and any type of cardiovascular disease. So the take-home points here: if your patient has no contraindications, consider an NSAID. And that's a small subset of hospital medicine inpatients, but it needs to be thought about in folks who don't have a contraindication. If your patient has a contraindication and pain is an issue, we also need to do a good job educating them as to why they can't take many over-the-counter drugs. So once they go home, they may start taking a bunch of drugs they're not supposed to. And so we probably need to do a better job of that, even if patients don't have uncontrolled pain, just educating them at discharge which over-the-counter drugs can be potentially dangerous for them. And then lastly, if you're planning on using NSAIDs for long-term or at higher doses or scheduled doses, your patients probably need to be on a PPI. Okay, so in terms of muscle relaxants, these work by blocking the neuromuscular junction by binding to acetylcholine receptors. So here's our nerve, here's the muscle. The nerve is going to transmit acetylcholine, which is then picked up by acetylcholine receptors in the muscle, which long story short, leads to an action potential and contraction of the muscle. Muscle relaxers block that junction, okay? So the primary indications for these drugs really only includes spasticity and muscle spasms. That's really the only two things that they are truly indicated for. But in practice, they're likely also at least partially effective in most types of musculoskeletal pain. Contraindications, you got to be really careful in the elderly, just like they can have problems with any drug that affects acetylcholine or anticholinergic drugs. These can have similar effects in the elderly. So in general, you probably should avoid muscle relaxers in these patients. So in terms of take-home points, I personally prefer methylcarbamol or Robaxin. Anecdotally, to me, this seems to be the least sedating. And so that's kind of my go-to muscle relaxer at the beginning. I would consider using this in any patient that's got musculoskeletal pain that's uncontrolled. Avoid in the elderly. Like we're going to talk about all these drugs, you need to get them off these drugs if they're not working. So if there's no noticeable benefit, you need to taper them off. All right, let's talk about gabapentinoids. So how do these drugs work? It's not as intuitive as I thought, and I realized that I misunderstood them when I started to read about it a little bit. Although they are very similar structurally to GABA, they do not actually bind to the GABA receptors in the brain like alcohol and benzodiazepines do. How they work specifically is more complex than I realized, but basically they help prevent the release of neurotransmitters that serve as an excitatory transmitter in pain perception and epileptogenesis. So they work in pain, and they're obviously can be used as anticonvulsant drugs. So these drugs are most effective in neuropathic pain. Now, if you look at the FDA-approved indications for gabapentin, it's actually really limited. I think it's like post-herpetic neuralgia, seizures, and maybe diabetic neuropathy. Gabapentin is probably the drug that we use most frequently off-label compared to virtually every other drug. That said, if you've got a patient that has uncontrolled nociceptive pain, it's certainly reasonable to try gabapentin, okay? We do need to be aware of the fact that at therapeutic doses, it's pretty common for patients to have side effects. Specifically, somnolence and dizziness are some of the more common effects that we see with Lyrica and gabapentin. And there's this growing awareness that these drugs do have an abuse potential, and that's what led to the scheduling of Lyrica a year ago or so. Now that said, I'd rather my patients be addicted to gabapentin than addicted to oxycodone. So you've got to weigh risks and benefits, but just be aware they're not as benign as we thought when these drugs really got popular in the late 90s and early 2000s. So take-home points here. If your patient has neuropathic pain, probably should have them on a gabapentinoid. Be aware of the side effects and the abuse potential. And like we said, if you're not noticing a benefit, get your patients off of these drugs. Now with gabapentinoids, you've got to be a little more careful because the withdrawals can be pretty unpleasant. So you need to taper them off slowly, okay? Okay. Now let's talk about our opioids. So let's approach this by talking about different principles for inpatient opioid administration. So a few things that you need to do before prescribing. Got to check the PDMP. Now, I don't think APPs have access to this. That's something that needs to be remedied on the state legislative level, which I hope does happen. But this is an enormously helpful resource, and you need to be checking it on virtually all your patients that are on opioids. We need to take a minute to screen for misuse. So if you're at the point where you're thinking about adding opioids for your patient, you need to inquire about a prior history of addiction or overdose or suicide attempt. And it's not always obvious by the patient's chart or how a patient looks. You know, a lot of patients have these histories and we don't even know it. That doesn't mean you can't use opioids in this population. We just need to be careful and be mindful about how we educate them even more than we would, you know, another patient. Which brings me to my next point. We really do a very poor job about educating patients on opioids. Okay, we've got to set expectations with them and let them know that our goal is to improve functioning, like we always talk about. We're not going to get our pain score 0 generally, and that's not our goal. So we want to improve, shoot for improving function as opposed to dropping a pain score. Now they may coexist, but that's not necessarily our goal. In terms of risks, we have got to go over risks and expected side effects. The patients also need to be aware of the potential addiction risk. When I was reading for this lecture, there's a large portion of patients with opioid use disorder who were first exposed to opioids as an inpatient in an acute pain setting, i.e. are doing. That's a large portion of these patients that otherwise or later get addicted to opiates. And the same study went on to ask these patients how often were they educated about opiates being addictive, and that number was really, really low. And so it seems so obvious to us, and it seems like it's ubiquitous information. We have to be intentional about educating our patients about the risks of these drugs, okay? Make sure you discuss alternatives to opioids. Like I've said, at this point, your patients really need to be on all these other therapies we've talked about. But oftentimes when you talk about the risks and addiction potential, patients will take the initiative and say, well, let's try one more thing before going to opiates. And then another thing that we don't do a great job with is discussing duration of therapy. You know, make sure that they are aware of what your plans are for the opiates and what your plans are for getting them off, okay? All right, now when it comes to the actual prescribing of inpatient opioids, this stuff seems obvious, but let's kind of go through it. So opiates for acute pain should be prescribed at the lowest effective dose and for a limited time. If you're treating acute pain, you should only use short-acting, immediate release formulations. As I keep saying, you've got to make sure you maximize these non-pharmacological therapies and these non-opiate drugs. Got to anticipate the side effects, specifically the bowel regimen, which we'll talk about, and if possible, avoid concurrent use with benzodiazepine. Okay, we're going to circle back around to this, but let's talk about the things you got to do at discharge. In general, you know, this is kind of my personal way of looking at it, and I know we sometimes run into problems with patients who don't have good PCP follow-up or don't have insurance or whatever. I think a general rule is patients don't need more than about a 7-day supply. With my work on the Opioid Stewardship Committee, talking to a lot of surgeons, even folks who have really invasive surgeries, are just getting a couple-day supply of opiates. So I think we probably overshoot with how many opiates we give our patients on a pretty frequent basis. It's really important you communicate with their primary care doctor if possible. I know that's hard, but that's key. And you want to, if the patient's leaving the hospital on opiates, you want to make sure the PCP knows what your plan was to get the patient off the opiates. And then you got to consider providing naloxone. Okay, so let's take a moment to talk about that. I'm not going to read through all these, but these are the recommendations the Opioid Stewardship Committee came up with. Basically, there's 2 categories. The first one being if your patient has has an active history of substance abuse disorder, you got to send them out on naloxone. Okay, and then for these other 9 categories, you should still consider it. And if you read through those 9 categories, most of our patients we give opiates to are going to fall into one of those categories, which I think the take-home point is every patient that you're sending home with opiates, if you're not sending them home with naloxone, you need to ask yourself why. It's not always needed, but that question needs to cross your mind. But let me say this, if you prescribe naloxone, you must educate the patient what it's for. Naloxone's got a stigma about it. Patients often don't understand why you're giving it to them. And I've been involved in cases where it's created problems with the pharmacy and it's created problems with a grievance committee after a patient's been discharged. Take 2 minutes to talk about why you're giving the script for naloxone, okay, and give them a chance to ask questions about it. Okay, so I want to kind of go over one approach to inpatient pain management. Now, when I say one approach, I mean my approach. This is how I like to do things, and I think it's the way to do it. So you can take it or leave it. But I think this is a reasonable way to approach pain management, acute pain management for inpatients. So I keep saying this: non-pharmacological therapies should be utilized and individually tailored to your patients. Okay, you need to be doing this for every single one of your patients that's in pain. Ask them how their pain is affecting them, and ask them what milestones in their mind that they could reach would let them know that their pain is getting better. You know, they may say something like, geez, I just want to be able to get out of the bed. And for those patients, we can strive for that, PT, OT, out of bed. So get their input on what they consider their goals to be, because it may be different than what yours are. You know, if they like animals, get pet therapy ordered. If they're into music therapy. These things are really effective, okay? So next, when it comes to non-opiate pharmacotherapies, like I keep saying, if there's no contraindications, all patients need to be on Tylenol and an NSAID. If there's a neuropathic component, consider a Gabapentinoid. If there's a musculoskeletal component, consider a muscle relaxant. Topical agents can be really effective. Order that when appropriate. And this last one is really critical. You've got to treat any coexisting psychiatric conditions. So I keep pounding on this because just like with our non-pharm therapies, we often forget about all these things, and we often get in the situation where, okay, well, let's call inpatient pain service. I can tell you, if you haven't done all these things, IPS is not going to see them on day one, or they're going to tell you do all these things, then we'll see them, or they're going to basically copy what's here and put it in their first note. A lot of the time, not every time, but the point is that these measures are as effective, if not more effective, than opiates. So we need to keep that in mind as we add opiates, and keep it in mind as we're consulting inpatient pain service. Okay. Now, I sometimes feel like you're adding a bunch of drugs to these patients. I've got them on Tylenol, and ibuprofen, and Gabapentin, or Relaxants, and SSRI. You know, it's not always an ideal situation, but if you're at the point where the patient continues to be in pain, we really need to make sure we're taking a multimodal approach and attacking the pain at different levels. Okay. So in terms of opiates, if you need to add opiates, my personal preference is to avoid combination medications. Now, the reason I do that is so I like to maximize the amount of Tylenol that they can be on, period. And then if I need to add opiates, I will. And using a combination drug can often get you in trouble with incidental Tylenol overdose. So I don't ever use a combination drug. I have them on scheduled Tylenol, and then I'm using a non-combination opiate, okay? My preferred oral agent is Oxycodone. I like that for a few reasons. Anecdotally, I think Oxycodone is more effective than Norco when using equivalent doses. Anecdotally, I find Oxycodone to have fewer side effects, specifically nausea. And if we ever need to convert it into a long-acting pain medicine at discharge, it's easy to convert Oxycodone to Oxycontin if that's the route you want to take. So, like I said, these are just kind of my personal preferences, but there's good reason behind it. My preferred IV agent is Dilaudid. I think that when it compared to morphine, Dilaudid tends to cause less itching, less flushing. And so I think everybody's going to get comfortable with the drugs that they like to use, and often not deviate from their preferences. And these are just kind of the ones that I like. And then lastly, you know, consider regional anesthesia if appropriate. Okay, so nerve blocks can be really effective, joint injections, radiation. I find myself sometimes forgetting we have these resources available to us, and we don't utilize them. We just go up on their opiate. Okay, so let's cover kind of a practical example of what a stepwise approach would look like. So for our non-pharm therapies, again, unless PT and OT is signed off, I want them seeing every one of my patients. Order these other things, as appropriate too. Educating a patient and setting expectations is really important. Letting them know that pain is a normal part of the process for most of the things that they have pain for. Letting them know how long we think that they'll be suffering from pain. We don't often do that unless the patient specifically asks. For non-opiate medical therapies, these are kind of this is the order set that I like. So, scheduling Tylenol 650 Q4 keeps us under that 3 grams a day, and it gives us a nice schedule. Ibuprofen, the doses, kind of range between 4 and 6 and 800. And then I utilize lidocaine patches a lot. When it comes to opiates, like I said, oxycodone is kind of my preferred oral agent, and my starting point is usually 5 Q4 PRN for moderate pain, 10 Q4 PRN for severe pain, and then Dilaudid 1 Q4 for breakthrough pain. So notice there's no opiate order for mild pain. There should never be a PRN mild pain that it contains an opiate. Okay, well, I shouldn't say never, virtually never. We shouldn't be giving opiates for mild pain. And these are just starting point recommendations. If your patient is not opiate naive, or if we know this isn't going to be effective, you can always go up. But what I'm trying to show here is for moderate pain, I like to have an oral dose. Severe pain, just a higher dose oral agent, and then only using the IV as breakthrough. Okay, we'll talk a little bit more about that. And then of course, you can't forget all these other considerations. So starting point for gabapentin, sometimes I'll do like 100 milligrams at night versus 100 TID. I mentioned that Relaxants is my go-to for musculoskeletal pain, 500 TID, and then you've got to address the psychological component. Okay. All right, so we'd be remiss if we didn't talk about some of the adverse effects of opiates. These are all pretty well known, but I do want to spend a little bit of time on constipation, okay, opiate-induced constipation. It's important to realize that while many of these effects, adverse effects of opiates will wither or be reduced with time, the longer the patient's on opiates, that's not true for constipation. So even if a patient is really tolerant to very high doses of opiates, this constipation issue remains a problem, okay? So opiates affect the GI tract pretty significantly in many ways. So they affect the sphincter pressure in the esophagus and in the distal part of the stomach, as well as the anal sphincter tone. They decrease digestive enzymes. They slow gastric emptying. They increase how much water and electrolytes are absorbed within the gut. But really the biggest contributing factor here is this one. So this intestinal peristaltic contractions are decreased, okay? And that's the biggest factor that leads to OIC. And then on top of that, we know that OIC is often exacerbated by coexisting advanced age or immobility or autonomic neuropathy or malignancy, dehydration. There's a lot of stuff that can make constipation worse in these patients. So when it comes to OIC, an ounce of prevention is worth a pound of cure. So it's much easier to prevent than to treat. So as such, anytime you order an opiate, you probably need to be ordering a bowel regimen, okay? This is the regimen that I like. So as I mentioned, decreased peristalsis is the biggest factor here. So the first agent that I usually order is an agent that'll increase peristalsis. So Senna and Bisacodyl can do both. Both of those can do that. I personally prefer Senna. I think that it leads to less cramping compared to Bisacodyl. And then I usually start my patients on a stool softener. Now, if you polled half the GI doctors at UAB, they'd probably say, DocuSay doesn't work. It may not work, but it has virtually no side effects. And I often add it to my bowel regimen. I never ever use DocuSay as a monotherapy for a constipated patient. That's totally worthless. But it can be thrown on as an additive. If that's not working, your next step is usually to add some type of osmotic laxative like Miralax or PEG. Enemas and suppositories are very, very effective if patients are amenable to it. And then don't forget about methyl maltrexon. Now, when methyl naltrexone first came out a few years ago, it was all the rave. You know, this drug that can reverse the effects of opiates only on the GI tract and nowhere else. On paper, it seems like it's a miracle drug. In my experience, it's really not that effective. I still use it pretty frequently if my patient's on a pretty good regimen otherwise and they're still constipated. So, you know, use it, but my experience is that it's not the most effective thing. Other things to think about. Avoid bulking agents like fiber. That really can make things worse unless the patient's really well hydrated. And in that same vein, you need to make sure your patients are hydrated. That's a big component of this as well. Mobility is critically important to getting the bowels to move. And there's some research that shows that probiotics may be helpful in opiate-induced constipation. Okay. All right. A few pearls / pet peeves. Let's talk about tramadol. Don't use it. Okay. Don't use tramadol. Okay. Let's discuss why. So tramadol is metabolized by an enzyme called CYP2D6. A sizable portion of the population does not have this enzyme. Genetically, they just don't make the protein that makes the enzyme, which means for those patients, tramadol has no analgesic effects whatsoever. You can see how that can lead to problems. If you've given a patient tramadol and they're still complaining of 10 out of 10 pain, so you go up and it's still 10 out of 10, it may not be that they're being difficult. It may be that they're one of these folks that don't have the right enzyme. So that reason alone is enough to not use it. On the other hand, when a patient can metabolize it, its metabolism is highly unpredictable. Some patients are ultra metabolizers, meaning they can be at risk for respiratory depression even at normal doses. Okay? Tramadol also weakly serves as an SNRI. And this is another drug that on paper, it kind of seemed like a perfect drug. You know, it can act as an antidepressant, it can act as an opiate. You know, many of our patients need both of those. But when it comes down to it, its SNRI effects are not strong enough to be felt in an antidepressant way, though it's just enough to have side effects from that. Okay, so you get all the negative with none of the positive. And of course, we all know it lowers the seizure threshold. So if a patient needs an opiate, there's better, safer, more effective options than tramadol. If a patient needs to be on SNRI, there are better, safer, more effective options than tramadol. There's really no good reason to use tramadol at all. Again, when it first came out, it seemed to have a lot of promise, but we've learned that it's something that you probably shouldn't use. Just as an aside, for patients that do have coexisting depression and chronic pain, the drugs that I do like are things like Cymbalta and nortriptyline. Okay, they seem to be a little bit more effective when managing both of those buckets. Okay, next pearl, IV analgesia dosing. So I see this order a lot. Dilaudid 0.4, Q6, PRN, severe pain, and no other order for pain control. That's it. And it drives me nuts. Okay, let's talk about why. So first of all, when it comes to Dilaudid, I think we frequently underdose it, both from a quantity standpoint as well as a frequency standpoint. For my opiate naive patients, I usually start at 1 milligram. Okay, and we can't forget IV agents very rarely stay within your system for more than an hour. 40 minutes, 50, 60 minutes, really the longest that drug is going to be felt. Okay, so if a patient's legitimately in pain and you've ordered 0.6 Q6 of Dilaudid and nothing else, that means that patient's suffering for 5 of those 6 hours. It's torture. If they're not in legitimate pain, the Dilaudid shouldn't be ordered anyway. Okay, so if you're going to order it, let's order it appropriately and order it compassionately. Okay, so the take-home point here is IV analgesia should virtually never be ordered as monotherapy. Okay, and they work best as a breakthrough agent. Okay, so if you remember this that I showed you earlier, this isn't a hard and fast rule, but using the IV agent as a breakthrough agent and these as your PRN agents for moderate and severe pain is really the most effective way that Dilaudid can be used. Now, there's always exceptions. Maybe you've got an MPO patient, maybe you've got a palliative patient that's dying and can't take stuff orally. Now, for those patients, things like a PCA pump or a fentanyl patch or whatever may work better. But say you can't use those. The point here is if you're ordering an IV agent for analgesia and you can't get something else in their system, it really needs to be Q2, if not Q1. I know that's hard from a nursing standpoint, but this 0.4 Q6 is insufficient as monotherapy. Okay. All right, elderly patients. When it comes to elderly patients, we really need to hit that Goldilocks zone. Okay. Now, I'm a bit of a space nerd, so I'm going to over-explain something that you guys probably all know. But the Goldilocks zone refers to the area near a star where a planet's not too hot, it's not too cold, and where water can exist in liquid form. They're kind of the basic necessities that determine whether or not a planet may be habitable, potentially habitable by humans. Okay, so what does that have to do with elderly patients? If you got an elderly patient who's in pain and you over-medicate them, it likely will lead to problems, including delirium. But under-medicated and under-treated pain is also a big contributing factor to delirium. Okay, so we really got to hit this green zone here in our elderly patients, and we need to be mindful of over and under-treated pain. So how do we achieve this? We all know this. Scheduled Tylenol is a must. Okay. Now, once that's done, low-dose opiates are often the best or the safest second-line agent. Okay. Don't be afraid to order opiates on your elderly patients. You need to be mindful that they need to be started on lower doses, but 2.5 of oxycodone is often much safer than NSAIDs or gabapentin or other things that we use in our younger patients. So the low dose oxy is usually where I go after Tylenol. Okay. Like with all of our patients, especially like with all of our patients, but especially with our elderly patients, these non-pharmacological therapies are incredibly important. Okay. So therapy of physical and mental kind, and if appropriate, no overnight vitals and labs. Okay. This kind of gets into the delirium conversation, which I don't want to, but just as a general piece of advice for my elderly or all your patients, frankly, if they're not critically ill or unstable and sleep has been an issue for them, don't check overnight labs. Check 6 a.m. lab instead of 2 a.m. labs. Don't only do that when it's clinically appropriate, but we need to be doing that much more often than we do it. Okay. So, these three things here relate to this piece of data that I found, and it was comparing the effectiveness of different therapies in terms of reducing pain scores. So look at those three things that I just mentioned. So physical fitness, through different therapies and being out of bed is the single most effective thing in reducing pain scores. This cognitive behavioral therapy and mindfulness, which we get through these avenues, is very effective. And just letting your patients sleep is effective. All of these things are much more effective than opiates. Okay, so opiates certainly have a place, and use them when needed, but don't forget about these things, which we often do. And these have no risk, essentially. Okay. All right. Just a few more slides I wanted to show you guys. So there are several resources within Impact, which I think can help with pain management that I'm not sure that everybody uses. So we have this Opioid Stewardship Tab. This was added a couple of months ago, I believe. It's got lots of different tabs here. So this is kind of the summary page. And there's a lot going on in this graph, so I want to point some things out. The x-axis here is time. So time between the two light green lines is 24 hours. So this shows your 48-hour view. This gray line is a patient's reported pain score. Dark green dots are individual dosing of opiates and their OME total, or their OME. And then the green lines gives you an OME total. This was a patient of mine that was admitted for cancer pain, I believe. Now this pain score here was actually taken after he got this, or right after, so it probably hadn't taken effect yet. But you can see his pain score goes down by the time he gets these agents here, and it gives you a total daily OME dose. Now, this is actually one thing we want to avoid, right? We want to avoid this roller coaster of pain scores from 10 to 0, 9 to 1, 10 to 2. Ideally, we're going to get it in the 6 to 3, 5 to 2 range, 4 to 3 type range. But this is a nice snapshot of what's going on with their pain control in relation to what opiates you're giving them. The other tab here for non-opioid medications lists all the non-opioid medications. It's a good view. So labs and events, I don't know what labs are triggered to be pulled in here, but mainly for events, this is helpful for last bowel movement. And then for non-pharm therapies, this draws in all the things that we've talked about. So this particular patient did PT and OT had signed off, and there was no music or pet therapy, but there were some nursing interventions about breathing exercises and that kind of thing. And that'll all be drawn into this tab. Now, I know, again, like I said, APPs don't have access to the PDMP, but when you click on the Opioid Stewardship tab, they should have this summary or this PDMP gateway, and which will pull in the big red flags from the PDMP. So I would say if you're an APP and you see these red numbers, that's probably when you should ask your collaborating physician to pull the summary for you. And if you're a physician watching, you can click the view report and it takes you directly to the PDMP report. So you don't have to go through a different browser and sign in with your 22-character password like they require you to have. It's linked with your Impact password. So click on report and it takes you right to it. So this has been very helpful. In addition to the tablet, there are some new power plans that we've developed. So this is still a work in progress. We anticipate adding others, but the ones that we have right now are standard and geriatric regimens, both for patients who can tolerate PO and those who are in PO. I use this standard PO regimen a good bit. If you click on it, it tells you, who you can use this power plan on. It's got multiple multimodal analgesics pre-selected. It's got topical agents. It's got PRN and breakthrough opiate options. It lists, if you've got neuropathic pain, consider gabapentin. If you've got musculoskeletal pain, consider these. It's got naloxone ordered. So I think this is pretty good. Now it does not include these non-pharmacological therapies. I want to tweak this a bit so we can get pet therapy and music therapy added here. I don't think anybody has a problem ordering those. We just forget about it. So if we can put it in the power plan to remind you that they're available, I think that would be a step in the right direction. But check out these power plans when you can. There are some older power plans in Impact still. So the new ones that the Opioid Stewardship Program has designed has this OSP in parentheses there. Okay. All right, that's all I got. Does anybody have any questions, thoughts, anything?
Hey Tim, it's Amy.
Hey.
Hey, I have a quick question. Because I'm on Tinsley right now, so those power plans are good to be used by anyone right now, so I can kind of educate my residents too. Okay.
Yeah, and you said that, something popped into my mind. I forgot now, but yes, these four here, if you just type in pain management, it'll give you, I think there's like 12 different things, but the four here from the OSP are all available. Oh, and they do say the way that they're designed, where did I see it? Oh yeah, so here it says discontinue all of the pain medications to avoid duplicate orders. So I often order this on admission. Again, it's not perfect, but I think it serves as a reminder to all these things that we forget about. But yes, these are live right now.
Excellent. And just as a question, just because I always find myself questioning, like when folks need enemas, what is your go-to enema? Because I feel like Fleets has some issues with it. I thought I'd throw that in there.
So yeah, great question. I should have talked about that. I use tap water enemas. The actual stuff that's contained within the enema is not as important as getting the rectal stimulation. So tap water is as effective as any other ones. Now, lactulose enemas are great for your hepatic encephalopathy patients who you can't get to take oral lactulose, and it does work as an enema too, but I don't use lactulose enemas unless I've got a patient with HE. If I'm trying to get a bowel movement, tap water is as effective as anything else out there. And honestly, if my patients tell me they're constipated, that's the first thing I offer them if they're open to it, because it's effective, especially if it's a distal problem. Nothing's going to work as good as an enema. Now, often these patients will have, colonic-wide constipation issues, and enemas don't reach the whole colon. But that's something else we underutilize because we're often, don't want to ask patients about it or whatever. But enemas are very effective, and I just use tap water.
Thank you.
Any other questions? All right, y'all let me know if anything pops up. Like I said, I've been doing a lot of work with the Opioid Stewardship team. There'll probably be some more educational opportunities coming from, not from me, but from the hospital as a whole in regards to this topic. But there's a lot of good resources out there. Okay. All right, guys, thanks for joining me. I appreciate it.